Good afternoon, everyone, and welcome to Grand Rounds today. My name's Tom Fardon. I'm one of the chairs of Grand Rounds. I'll keep it brief at the introduction this week as I recover from recent surgery, of which I should mention again my gratitude to the anaesthetic and ophthalmology teams in Ninewells for their work and saving my eyesight once again. Last week was cancelled because of me having an operation at the time, so I'm grateful to the orthopaedic surgeons who stepped to one side, and they're going to reschedule for some time in the autumn. So we look forward to welcoming them back, probably September, October time. But this week, my friend and colleague, Dr. Fiona Cameron, is going to talk to us about the 2021 Foundation Programme curriculum. And she's just the right person to talk about this because she's the Foundation School lead for Scotland, as well as being the Associate Postgraduate Dean in the East of Scotland, responsible for foundation training. And she co-wrote this curriculum. We'll all be aware of the shape of training is changing how we train our doctors. And foundation is a key part of that. So if you're involved in training or assessment of foundation doctors at all, whether you're a doctor, nurse, allied health professional, or a member of the university staff who's involved in assessing our foundation doctors, this will be really important. So thanks for tuning in, and thanks very much to Fiona for coming along to Grand Rounds today. Any questions for Fiona, please put them in the chat or stick your hand up at the end and we'll try to get around the room. Thanks very much, Fiona.
Thank you very much, Tom, and thank you everybody for joining this. Yes, as I say, my name is Fiona Cameron, I'm an anaesthetist, and I still do give some anaesthetics, but a good chunk of my work now is about managing the foundation doctors across Scotland and in the East region, and I have been fortunate enough to chair one of the Academy of Medical Royal College's committees looking at assessment of the foundation doctors. So I'm going to talk to you about the 2021 curriculum because it is quite different, and it has a relevance for other curricula because all postgraduate curricula are going the same way. This is foundation. We're ahead of the curve quite some time ago when we had an outcomes-based curriculum, and all other curricula are becoming outcomes-based. But despite that, the foundation curriculum needed to be updated and rewritten, and this is a fairly major rewrite at this time. And I think the big thing is the assessment strategy is completely different, which will take a little bit of getting used to. So breaking it down into three different parts of this talk, I'm going to talk about the aims of the foundation programme curriculum, how we're actually going to embed the curriculum within the foundation training, and how we're going to assess the doctors at the end of it. I think a really important thing for us all to remember, and also for the foundation doctors to remember, that they are in a training programme. They are not just the ward docs who do all the Clarkins, take all the bloods, do the ECGs for the rest of us to come and make decisions. These are doctors on a training programme. They have an educational curriculum to follow. They have achievements that they must require, and they have a standard to meet in order to get signed off into the training year, into the next training year or beyond. So I think that's important to remember. They are on a training programme. They are not just our ward docs. I think the big thing that we're going to have to get around is that this is not a tick box exercise, and there's been an awful lot of complaints over the years that doing the curriculum is just getting ticks in the boxes. How many SLEs have they got? How many workplace-based assessments? How many mini-KEXs essentially? But actually, we're going to be looking at more about actually achieving outcomes, and that's where those of us who are supervisors and assessors are going to have to start getting our heads around that and actually think about quality of information rather than just quantity of data. So let's start by thinking about the aims of the foundation programme. Those of you who are involved in specialty training have a selection process. Foundation doesn't have a selection process. Foundation has a ranking process. The foundation programme across the UK takes all graduates coming from medical schools. We haven't got the privilege of saying, we will take the top X number. We take everybody. We take doctors from the UK, and from out Europe and out with, and then also the rest of the world. Everyone comes with the standard amount of medical knowledge, but not everybody is trained to the same, not everybody has the same training and is ready to start foundation at the beginning. And that's really important because we welcome all our medical graduates from across the world, but we recognise that not all of them have the same final years in medical school as UK graduates. So we need to be cognizant of that and remember to ensure that our doctors from overseas are welcomed in and are allowed to develop to reach the same requirements as everybody else. So we have critical points, we have pinch points, critical progression points as we call them. And the first one of those is the completion of F1, at which point the foundation doctor gets full GMC registration. This is obviously, that first ARCP is really important. It's a summative assessment of whether they are actually fit to progress as doctors into foundation year 2, or whether they need to have further training. And I think we try and think of the F1 year as not necessarily 12 months. We understand that some people take longer and some people are ready in 12 months. So we are flexible within that 12 months, and we actually offer people extended time if they need it, because it's reaching the end of that point that's important, not necessarily the full 12 months to get there. And that's a really important concept. So at the end of F2, they get their FPCC, they get their certificate of completion, and at that point, they're ready to move on to whatever they want to do with the rest of their careers, whether that be going to GP training or specialist training, or take a circuitous route via some clinical fellow jobs, and then into their chosen specialty. So there are critical progression points. Unlike other curricula where you may have 2 or 3 years at core and then several years in specialty, each year is high stakes for the foundation doctors, because it actually means that they will be completing something quite important for them. So thinking about the curriculum per se, there's a real shift in the focus of the foundation curriculum, and we're not producing doctors that are ready for one type of specialty training. We're not producing anaesthetists, we're not producing surgeons, we're not producing GPs, we're producing doctors that are ready to enter any of those specialties. And there's a real focus on the parity of physical, mental and social health, and none is more important than the other. And for the trainee, they must think of each patient as somebody who has a potential physical health problem, their relevant mental health problem, and how that fits in with their social environment. So we expect them to think of a holistic approach to our patients, and we're looking for them to provide evidence of in their training and in their portfolio that they have considered all those aspects for the patients. We're expecting them to be educated across a variety of different sites. So that will be, obviously, we've got the acute setting, which is what traditionally we feel that we have always done. But we expect most of our doctors to have a community or primary care post as well. And certainly within Scotland, we are aiming within the next 2 years to have every 50% of our doctors having a GP post. We're hoping to increase the amount of exposure to mental health posts. We're hoping to have more of them in community placement, so that might be community paediatrics or in the community in obs and gynae. So we don't just expect them to be in a medical ward or a surgical ward. We're looking for this whole range of educational experience where the trainee can actually achieve their curriculum outcomes. Some time ago, there was a program, and I'm not sure if it's still ongoing, in Canada, where the equivalent of foundation doctors do their whole foundation training in general practice. And they can achieve everything that they need to achieve in their curriculum without setting foot in a secondary care setting. We haven't done that, but we have got some initiatives where we increase the amount of time they spend in the GP practice, and I can speak to to people at other times about our GP Lift programme, which is very similar to our longitudinal clerkship in undergraduate medicine. But I'm not going to focus on that. I just want to drop that in there just to hopefully interest some people. And we are piloting in the East in the next training year. Now, the GMC, I had to work quite closely with the GMC, which was quite an interesting experience for me. They were quite clear about what they wanted, which was good, because it meant that we didn't go down the rabbit hole of the wrong route. But their message was reduce assessment burden, but make sure the trainees are properly assessed. That was their big message, and that's where it has been quite challenging. So we now have 3 higher level outcomes, and this is what the trainees will be signing off, and they will be mapping all their evidence towards evidencing these 3 higher level outcomes. We used to have 4, but we're now down to 3. So thinking about these in turn, if we start with HLO1, they are clinician. I'd like to think of them as accountable, capable and compassionate in their clinical work. And underneath each of these HLOs, they're underpinning professional capabilities that we expect them to achieve, and I'll talk about them shortly. HLO2 is an interesting one. We felt that it was really important to recognise that the foundation doctor is a doctor working in the healthcare system. They're not on a placement, they're not on a secondment, they're not supernumerary, they're actually in a job, and recognising that there are commitments of you being in a contractual arrangement with an employer. We have had comments such as, do I have to turn up every day? The answer is yes. If you're on the rota, you have to turn up to work. So it's just about getting that transition between being a medical student where, you know, and that things don't need to necessarily be in every single day. When you're employed, you have to come to work, and where the foundation doctor fits in, and where the doctor fits in the multidisciplinary team. So we felt that was really important to actually have that as an outcome, that they need to evidence that they are actually in a job and coming to work. The other thing that's really important, and we wanted to have as an assessment, is, are they a professional learner, and are they lifelong learners? Have they set good habits early on about developing their portfolios, developing knowledge of the wider aspect of medicine, whether it's a career or other aspects such as academia, QI, whatever. So recognising that they are lifelong learners, and that when they finish medical school, learning does not stop. So we're actually going to assess their the way they perform in developing their portfolio, which we want to stop this kind of lastminute.com where, you know, 2 minutes before the ARCP evidence has to be submitted, that they finally put a whole load of evidence in, because that is not the way we want to train them for the future. So that's what we'll be signing off, and if you're an educational supervisor or a clinical supervisor, that's what you will be looking at towards the end of their post, to see whether they are meeting those requirements. So you're going to have to think a little bit about this. Now, as I said, each of those HLOs are underpinned by these professional capabilities, and these are based obviously on the GMC's general professional capabilities, but in foundation we call them foundation professional capabilities. And you can see that underneath each of them there are a few FPCs. Now, when the trainee comes to link the evidence, they will be linking to these FPCs. And you can see that they're all quite different. And what we've seen in the past is foundation doctors doing one of their SLEs, so they maybe do a mini KEX, and what they then have done is linked it to every single FPC in their curriculum. Well, we can't have them doing that. There's no point in saying that you're looking after somebody's chest pain and then, you know, linking that to FPC 12 or FPC 7. So they used to just link, it used to just be link, you know, frenzy. Everything they put in, link. So actually we're asking them to think about what they're linking. So if they've looked at somebody with chest pain, then what are the aspects of that? So yes, they might want to link their mini-KEX to clinical assessment, clinical prioritisation, but we also want to maybe think about where that sits with the patient's social environment, how that affects their mental health, whether they are aware of any QI work that might go involved with that. So we want them to think more about just linking throughout, thinking one thing to everything. So they're going to have to be a little bit more selective. We as supervisors are going to have to look at what they've linked and to see whether it is appropriate or not, and actually say, no, that's not an appropriate link, that needs to be unlinked and start again. So that's what the curriculum, that's what TURAT is going to look like, not exactly in this way, and I've got some screenshots, but essentially these are the topics that we have. Now, underpinning each of these FPCs, we have a series of behaviours. And the behaviours are things that they might want to link. Now, I haven't got a slide of that just now, but when they click on, say, clinical prioritisation, underneath that will be a list of behaviours that an F1 would be expected to do, and a list of behaviours that an F2 would be expected to show. We're calling them behaviours rather than competencies, and it's to give the trainee some guidance as to what sort of thing they might want to link. And we've got behaviours for all of the 13 FPCs to give them some guidance, and also to give the supervisors some guidance as to what they think might be reasonable links. The curriculum at F1 and F2 is the same. There is no difference. So we're thinking about spiral learning. What they do at F1, they will revisit in F2, but the behaviours are different. We expect more of them as an F2 than we do of an F1. So they'll be experiencing spiral learning with revisiting their curriculum, but behaving in a more mature and competent way in F2. Okay, so how are we going to deliver this curriculum? Because there's quite some differences. Now, I'm not sure what everyone thinks, but sometimes I find that the trainee doctors say, oh, I don't get taught anything, I don't learn anything. I think sometimes they need to be signposted that everything they do in their workplace is experiential learning. I think what probably wasn't experiential learning for me, to go back to the 1990s, was filing all the full blood count reports. That probably wasn't experiential learning. Just see how many bits I could get to stick in one of the little sticky bits in the notes. But that probably wasn't. But I would say now everything that they do is experiential learning. So when they clerk a patient, when they go on a ward round, when they see a patient in a clinical setting, this is learning. It's learning from us as the senior clinicians. It's learning from the nursing staff. It's learning from our other colleagues and our whole multidisciplinary team. So they're learning clinical material, they're learning knowledge, but they're also learning behaviours, they're learning approach, they're learning how to prioritise and how to communicate. So we call this experiential learning, and we want them to record experiential learning. And we record experiential learning by SLEs, or what we call in other specialties is workplace-based assessments. They haven't gone away, they are still there, and we still use DOPS, mini-KEXs and CBDs, etc. We have developed some work with the UK FPO to talk about how to do an SLE. So there's a little talk that we have prepared, and some videos on what an SLE is, how to do it, how actually just the logistics, who to ask, when to do it, how to fill it in. So we've got some information there for trainees. So we focus very much on experiential learning. We also then focus on direct learning, and that is what they are taught. And I think sometimes they think, unless they're actually being sat down and said, so you are being taught, they don't think they're learning. But we have direct learning, and the direct learning we think about is core learning and non-core learning. The core learning is the learning that we deliver as the organisation, as based on their curriculum. So the deaneries, so certainly in the East region, we in the foundation team we deliver their, or we plan, we don't do the delivery, but we plan their core education. At the moment, that's basically done on Teams, but I'm hoping to go back to face-to-face when we're finally allowed back into the Ganachie and into the Wolfson. But we expect our trainees to have 30 hours of this core learning in a training year, which should be achievable. It's not really that much. It's less than 1 hour per week. If you think that they have 42 weeks, you know, well, maybe they're probably trainees have more than that because they don't get any study leave. So probably they're looking at about 48 weeks of being at work. Therefore, they should manage to go to 1 hour a week of their deanery delivered education. There's some of it we will be delivering as a foundation school level, and I'll talk about that in a minute. And when I come on to that, you'll probably see why. We're also expecting them to have 30 hours of non-core learning, and that is anything else that they choose to learn about. Now, this is my plea to you guys. If you are offering specialty-specific teaching, or departmental teaching, please invite the foundation doctors if you possibly can, because they can record this as their non-core learning. That could be M&M meetings, any kind of balance groups, short rounds, any teaching that you do within your department. Please invite the foundation doctors and they can record it. We're really keen that the foundation doctors don't sit at home and do all their learning. We hear, I mean, the trainees are tired, they're exhausted, and they do work hard. And what we don't want is for them to basically watch all these sessions on Teams when they go home in the evening. I know we all do it. And I know that it's reasonable to do some of it, but we really don't want it to be that they have to go home and do all their learning at home. We also think about self-development learning. So self-directed learning is things that they may choose to read about. So journals, e-learning modules, whatever interests them. So these are the type of learning that we signpost the trainees to, so that they do realise that they are learning in the workplace. One of the things that we found by doing some sort of focus groups is that some supervisors are not necessarily particularly au fait with the different responsibilities that they have. This talk is for the whole of Scotland, so some programmes are not 3-4 month posts. There are a few 6-month posts out there, predominantly down in Dumfries and Galloway, but I won't focus on that. And I think one of the things that we have to think about is the difference between a clinical supervisor and an educational supervisor. And in Scotland, as you know, the clinical supervisor and the educational supervisor are usually the same person. Although with COVID and with some of the medical specialties, we've split the posts in order to give trainees 2 months of, say, AMU and 2 months of a base specialty such as respiratory or gastro. The clinical supervisor and the educational supervisor roles are different. They are both GMC recognised roles. The clinical supervisor role is quite explicit within this new curriculum about what that actually is. And the clinical supervisor makes sure that the doctor is actually doing their job properly and that they're supervised to do their job properly. So as a clinical supervisor, you're actually commenting on their competence as a doctor in your unit. Are they meeting the requirements of an F1 or an F2 in your unit? And that is what a clinical supervisor should be feeding back on. The educational supervisor role is more about have they achieved their educational curriculum. So there's two different aspects to it. And because we have usually the same person doing both roles, then we have combined forms. But if you think about your role as a supervisor, you have both that clinical supervisor. A, are they a good doctor? Are they competent at that level? And B, have they met their educational achievements? So there's two very specific questions that we are asking. The PSG is something that's new this year. The PSG, the Placement Supervision Group, is new to Scotland as a mandatory requirement, and actually we've made it mandatory throughout the whole of the UK. The GMC were quite keen on this, and essentially what the PSG does is formalizes that departmental or corridor conversation, if there's any, about the foundation doctors, so that we capture a lot of information about their competence and their performance. So the placement supervision group is the group of clinicians, senior nurses, pharmacists, physios, etc., who see that doctor working clinically in the clinical environment. And there is now a form that can be sent by the clinical supervisor to a selected group of people in your unit to gather feedback on that trainee. And the feedback that it looks for is mapped to the domains of good medical practice by the GMC. So it's clinical care, safety and quality, etc. It tells us different information from the tab, the team assessment of behaviour. The tab tells us whether they answer their bleep on time, whether they're accessible, whether they're nice to the patients, and whether they can communicate. And actually, the trainees at the UK group summarised it quite nicely. They say that the PSG tells them if they're a good doctor, the tab tells them if they're a nice person. And they really value the feedback from the PSG. Also, within the PSG, there's little boxes where you can comment on areas of excellence. And of course, as doctors, we all like to be excellent. We don't like to be average or have no concern. We all like to be excellent. So this really very much feeds into that. But it's areas that they can use for it's something they can use when they're applying to specialty. They can say, look, I got a PSG form that said I was particularly good at managing patients with acute coronary syndrome. I knew exactly what to do. I managed the guidelines, etc., whatever. So we can put good things in the PSG, so that the trainees like it, but it also gives them feedback on their knowledge, their skills, their behaviours, more than just whether they're nice and whether they answer their bleep. So they're asking very different things. And going forward for this curriculum, we're going to be asking for 1 tab and 1 PSG per training year. And we will very likely be asking for these in the first 2 posts, because we can't ask for it in the 3rd post, because if there are any concerns, there's no chance of the trainee being able to remediate if the first time they find out this feedback is in post 3. So that's new, a mandatory PSG as well as a tab. Okay, this I'm not going to go through basically the roles are, as you know, we have an induction meeting, we have a midpoint review meeting ideally, and we have an end of placement report. But the supervisor's role is also about pastoral support, professional development, careers advice, or just being there for them. And I know that many of you as supervisors have been fantastic with that pastoral role for our foundation doctors. So it's very much appreciated by the foundation school. Now, I said I'd talk about the curriculum, and this is basically the core of the foundation curriculum and syllabus. And you can see that these are very high level topics. And underneath those, we are going to be basing our teaching programme on. Now, there are some that are going to be, I think, quite challenging across the UK, actually. And the areas where I see that we're probably going to need to do things across Scotland will be along things, so leadership, QI, careers guidance. The Scotland Deanery is developing a careers guidance group specifically for foundation and doctors, because obviously that's where they're going to choose their jobs. That's where they're going to choose which career they're going to go into. It's right at the very beginning, so we need to get in there early. And the one that I'm really concerned about, and I'll be looking for volunteers, is use of new technologies and the digital agenda, including genomics. So if anybody has any idea what that really means, then please tell me and put their hands up, because we need to prepare doctors for the 21st century. We need to prepare them for things that are coming out, and very much things are genomic. I joke, I do know what that means. But, genomics, new technologies, whether that be, equipment, or whether that be amazing new techniques, and patient-tailored therapies, then that's what they need to start learning about now. They need to be aware of it. So the foundation school is going to be delivering these at an essential basis across Scotland, so that across Scotland all trainees are exposed to the same education on those slightly more tricky topics. So please get in touch with me if you think you can help out, or somebody who is an inspirational speaker on some of these topics. I'd be very grateful. Now, their non-core learning we've covered. This is what they can attend. So really, I'd be encouraging you to let them attend everything that they possibly can, and try and free them up from the ward. Self-development is self-explanatory, really. Now, this is assessment. So this is what we'll be doing as supervisors and clinicians in the ward. So they're using the e-portfolio, and they're still using TURAS. That hasn't changed. It will look different in that the wording will have changed, the HLOs will be there, the FPCs will be there, but actually in terms of format, it's going to look really quite similar, so that there's not any major changes there, but how the trainees link and what the trainee platform will look like once it's completed will be slightly different. So obviously what we're looking for is their learning, their clinical supervisor's report, their educational supervisor's report, their reflections, the PSG and the tabs. We want all those into their e-portfolio, and once we've got that whole picture, we'll be able to decide whether they are competent and ready to move on to the next stage. Now, this is fairly sort of basic educational speak, and I just want to really focus on it a little bit about the hierarchy of evidence. I said earlier on that trainees tend to just put one, use a piece of evidence and link it to everything. Well, we're not going to do that going forward. We're going to recognise that there is a hierarchy of evidence, and for each FPC, we would really like to see a range of evidence from this hierarchy. And so at the bottom of the pyramid, you've got no's, have they been to the lecture? Have they passed the exam? Do they know how? Have they thought about how they might do it? It's been explained to them, they've reflected on it. They may have shown how to do something, such as, in simulation, whether that be high fidelity or low fidelity simulation, both are equally good. And the culmination of their evidence is really the experiential, so they're doing it. So they're showing you in the ward that they can do it. They can do the clinical experience. They have the behaviours, they have the communication, they have the safety. And what we're looking for is for them to upload some evidence from a range of these types of evidence for each FPC. So if we think of an example, so as I said, I'm an anaesthetist, so let's think about an epidural. If I was to put an epidural in and I want to show that, and I think, okay, so FPC1, I'm, clinical care, right, okay, so how am I going to use my epidural that I've asked to do a mini kex on to show that I am a competent doctor? So what I would do is I would link several pieces of evidence. I would link the fact that I've been to teaching on epidural. So I would link my knowledge on my evidence that I'd completed my physiology, pharmacology, anatomy. So I would probably put that in. I'd link that. I've been to that teaching. I know what an epidural is. I would then probably put in a piece of reflection to say, well, how would I put it? Who should get an epidural? Do I feel that I'm ready to put an epidural in? What do I need to know? Then I might do it on a back. I might show some simulations. So I might use a back simulator to show somebody how I could do it, or I might have used that in the exam where I've actually passed the exam, showing how to put an epidural in. And then the top bit is I'd ask my colleague to watch me doing an epidural, and that would be my SLE, that would be my mini kex. And I would say, watch me do this, and they would comment on whether I knew how to do it, how my skills were, whether I was aseptic technique, and whether I was safe and actually put the needles in the bin and cleared my tray. Okay, so that's the kind of thing that we are looking for each of the FPCs, particularly HLO1, which is the clinical ones. So for each of the clinical ones, we are looking for 4 or 5 pieces of evidence to map, to show that they have understood these competencies. We're not looking for them to map every bit of that curriculum, like QI, safety, holistic planning. We're not looking at that. We're looking at frailty. We're looking at, have they shown that they are a competent doctor, and they can choose any clinical scenario that they want to do, because of course they all do different posts. So they could choose a clinical scenario and put in this evidence to show that they've got that rounded, sort of complete sort of look at everything that they have done for that. So that's what we're looking at. We're also looking at the parity of mental health and physical health. So for each physical health SLE, we're looking for something equivalent in mental health. So for an acute situation, they may choose something like an acute coronary syndrome, but for an acute mental health problem, they might be looking at, say, maybe a delirium, or a sort of acute psychotic reaction. So we're looking for physical and mental health. And for the mental health ones, again, we are looking for exactly the same. Have they got the knowledge? Do they know how to implement that knowledge? They may have done some simulation. They have been down to the ward sim environment and done some communications with mental health scenarios. And then they actually finally get to do it in the ward. And actually in Scotland, we are extending our simulation programme, and all foundation doctors are going to get a mental health sim as well as a standard sim. So we're very excited about that new development. So that's where it's going to be very different for the trainees. And that's where it's going to be different for us as supervisors, because we want to see that range of evidence. And it kind of makes sense, but it is different. It's different to what we have done before. HLO2 is going to be very much linked by things like their tabs. They're developing the clinical teacher, any leadership activity they've done. And HLO3, we're going to be evidencing by what they've done in their teaching, what reflections that they've done, and any tasters and careers sessions that they've attended. The other thing that's really important to think about in this new curriculum, and it's actually stated, is what's the difference between a formative assessment and a summative assessment. So everything that we do formatively feeds into the summative assessment, but the actual summative assessment is down to the CS and the ES. And the CS and ES are the actual people that say, yes, this doctor is ready to move on, or no, this doctor is not ready to move on. So as a clinical supervisor, if you feel that that doctor has reached that level of competence, what you say is really powerful. It's really important. Yes, they are ready to move on to the next stage, or no, they are not ready and they need time. And very much the foundation school is delighted to offer extra time should the doctors need it, because it's reaching the end point, not how quickly they get there. The same with the educational supervisor's reports. The education supervisor is saying they have met their curriculum requirements or they haven't. Now, the only other summative assessment is the prescribing safety assessment that F1s have to have by the end of F1. Some of our doctors come without the PSA because it's not always delivered in medical schools. Those who haven't got it don't have to be supervised to any higher level in their prescribing, because it's an end of F1 requirement. However, if you do feel that that doctor needs extra support, then obviously they must get extra support. But having a PSA doesn't mean they don't need extra support for their prescribings, but it's just a little loop, little test that they have to sit and complete by the end of F1. So the two new things that we're putting in this year are the PSG, which I've already talked about, and the summary narrative, and I'll talk about that shortly. I'm not going to go through all the SLEs because these haven't changed. There are a couple of new forms that we have included. So the Learn form has been piloted in the West Midlands, and it really is a form that can be used to record any SLE on. It stands for Learning Encounter and Reflection Note. And basically, you can put a CBD, a mini KEX, or a DOPS on it. But there's a little bit for the trainee to reflect on it. There's something for them to say where they might want to go and learn next, what they might want to do. So it's got a little bit more information than just the straight SLE forms. They're not mandatory forms, but the trainee may want to complete them. So if you do see one in a portfolio, that's what it is. Same goes for the leader form. The leader form is for them to show any leadership activity. Again, they can just write this as a reflection, but if they want to use a form, there is a form there for them to put any leadership activity. And remember, leadership activity can be high level or fairly low level. So it could be leadership in the ward, it could be teaching medical students, or it could be being a rep. It doesn't need to be, but it's actually about how they show that they have leadership skills. The DCT form hasn't changed at all. Now, the big difference here is that we haven't put a mandatory number of SLEs in, and we haven't had a mandatory mix of SLEs. And we know that a few years ago, we took away a minimum requirement, and most foundation doctors did about 4 or 5 SLEs per post. So the focus here is on the trainee trying to maximise their experiential learning, because it's really high level. It's really important. Remember, it was right at the top of Miller's pyramid. So the GMC were absolutely straight on this. They said, you cannot put any numbers in. And this is coming to all curricula. So I snuck in a thing saying, so it's likely that the trainees will do about 12 to 15 SLEs. The GMC came back and said, no, take it out. You're not even allowed to give a recommendation. So there is no recommendation. However, we would like to see the trainees doing somewhere between 12 or 15 SLEs. This is going to be quite difficult. Most of them, I think, will do loads. But as supervisors, we can say, look, you've not met your curriculum outcomes, go back and do some more. And that's where it's going to be quite difficult. I think I've commented on this. This equity of physical and mental health is really important. And the trainees need to be signposted that even if they're not doing a mental health post, then many of our patients in hospitals and in general practice have mental health problems alongside their physical health problems. So they need to be reminded that even if they're not in a mental health post, they can achieve these outcomes. And we're hoping that also by doing a specific mental health sim, that we actually address some of those educational requirements as well. I've talked mainly about the PSG, the Placement Supervision Group. The trainees really like it. It will be the clinical supervisor that initiates the PSG, and there's quite good functionality within TURAS. But as a clinical supervisor, you send out the tickets to your colleagues, and the tickets get sent back to you, not the trainee. But it works the same way as a tab. And this is what it's going to look like on TURAS. When you're filling in the clinical supervisor's report, will put in your colleagues' names and email addresses. That will then be pushed straight over into the tab, into the PSG tab of the trainee's portfolio. And then when you're ready to send that out, say 2 months into the post, you click one button and all the tickets go out. And then they all come back to you. So you don't have to do multiple clicks and multiple emails all the time. So we're hoping that makes it reasonably smooth, and obviously we'll take feedback on that. They still have to do a tab, but only one tab, but it has to be satisfactory. Anyone that gets an unsatisfactory bit in it has to do another one. Teaching we've covered, 30 hours of core, 30 hours of non-core. And this is a new thing, the summary narrative. And this is a type of reflection that we want the foundation doctors to do. And essentially, it maps to what we do as consultants or non-training grades. It's a written reflection cataloguing what you've done in that year. So we do it for our SOAR and for our appraisal. We write in these little boxes why we think we have met the requirements of good medical practice. Well, we're going to ask the foundation doctors to do exactly that. There is one form that they will create, and it will run for the whole training year, and it needs to be completed by the end of their third post, so ready for ARCP. We're going to look for one reflection per HLO, so we have 3. And essentially, we're going to look at something like, so for example, if you look at the compassionate, capable doctor, HLO1, they might want to start at the end of their first post and say, I don't think I've met this yet because I've only done 3 SLEs and I haven't shown that I've got any mental health SLEs yet. I'm going to aim to do this in my next post. As they progress, then at the end of their training year, what we're looking for each of the HLOs is 300 words max that says, this is the evidence I've selected. This was the HLO, and this is the reason I think that I have met this HLO. It will allow you as supervisors to get inside their heads and see what they've been thinking. Why did you choose that evidence? Why do you think that you have met that requirement? Now, when I was at the assessment committee, when I chaired the group, I was so excited. I said that we're going to be well ahead of the curve in foundation. We're going to do this. The mental health college said, the psychiatrist said, we do that. The paediatrician said, we do that. The GP said, we do that. So we're not ahead of the curve, but we're going to start this in foundation. We're not expecting great shakes from the foundation doctors because this is their learning. They're learning to be selective about what they're presenting for appraisal, for completion of their curriculum. So we're going to have to help guide them. We're going to have to support them in doing this. They will have to do one, that will be mandatory, but I know that the quality will improve over the years. We're hoping that it actually helps them look at their PDP, and the supervisors will help them think about what they might want to do in the next post. That's what it's going to look like on TURAS, one sheet with their name at the top, and a little box for HLO 1, 2, and 3. And they can edit it over the years so that it will edit and save. And then they might come back and go, actually, no, I want to change that. I want to put something else in instead. So that's what they can do. The summary narrative will sit on their curriculum page. And as you can see, this is what it's going to look like. You've got your HLO 1 with your FPCs underneath it. And each of the HLOs look like that. The ARCP guidelines will be embedded within TURAS so that you can see that. Within the curriculum, there's some mapping, so what gives them some guide as to what they might want to map to the outcomes. When you are doing your CS and ES report, it's important that you review all their evidence. So you review their summary narrative, you review their tabs or their PSG, look at their evidence and try and work out, have they put the right evidence into those different FPCs. Get information from your team, and actually that will be documented through the PSG. And then when you're ready, you write your summative assessment, your pass-fail assessment for the trainees. Now, one of the questions I'm often asked is, why do we need to have the VAS block in by the 31st of May? And I just take a moment to explain why we have to do that. We're kind of pushed by the GMC in this. So at the end of the training year, the F1s get full GMC registration. Across the UK, there are about 7,500 F1s that are ready to get full GMC registration, and it's a lot for the GMC to process it. If we ask them to have everything in by the 31st of May, that allows the FPDs a week or so to review the evidence. Because remember, they're looking at 30 doctors' evidence and they need to look at the portfolios properly. You can't just have it submitted one day and look at it the next day. They need to be properly reviewed. So that means we do our ARCPs early June. If they don't have enough evidence in, we need to give them another couple of weeks to get that evidence in. That takes us to late June. And then the GMC require all the doctors to be uploaded by something like the 4th of July. So it is a very tight turnaround time. And that is why we need to have things in by the 31st of May. To be honest, most trainees who are progressing well will just be a straight yes, absolutely no problems. But we can push some back a couple of weeks if we need to. Mentioned the PSA, it has to be within the first, done by the end of F1. This slide, which anyone wants to look at, is really just which bits go into whether it's a supervisor, an education supervisor's or a clinical supervisor's report. And new for this year, the foundation program director is going to complete a report looking at that longitudinal educational aspect of the foundation's training year. I'm not going to talk about too much about the ARCP, but where there is no fixed number, it's all about quality, not quantity. The ARCP requirements are published every year on the UKFPO website, and I'm definitely not going to read those out to you because it really is just a summary of what I've already said. So, summary of what's new and what's not new. So there's new HLOs and new FPCs. There's a real recognition of the hierarchy of evidence. There's a real focus on mental health, not just physical health. There is no minimum number of SLEs, no maximum number. It's all about quality, not quantity. We're requiring 1 PSG and 1 TAB per training year. We're making the summary narrative mandatory. The core procedures have been removed, so they don't need to sign to say they've done a subcutaneous injection. And ALS and ILS courses have been removed as specific requirements. The trainees will have to evidence that they have those outcomes, but they don't actually have to do that within an actual specified course. The Foundation School are going to continue to fund ALS courses if the trainee wants to do that, but if the trainee finds an alternative way of evidencing those outcomes, we will accept that. The vast majority will do ALS courses, I'm pretty sure of that. Again, this goes for all curricula. All capital letter life support courses will be removed from curricula, but the competencies won't be, and that is a GMC mandate. What stays the same? The jobs, the supervisor's reports, the PSA, the learning, and the QI. And there's lots of information on the Scotland Deanery website and on the UKFPO website, where there's a whole series of little podcasts, videos, fact sheets that you can go and have a look at. So that is me. Thank you very much for listening. And I can take any questions if you have any.
Thanks very much, Fiona. My question was going to be that the PSG system as it currently is on TURAS is incredibly cumbersome and massively time consuming. But you've already answered the question in that that TURAS is going to have better functionality. Is that right? Absolutely.
We could, you know, the PSG was a requirement from the GMC and also the trainees really want it. The way we had it in TURAS was awful. It was absolutely awful. It will still require the clinical supervisor will have to then, when they're doing the CS induction form, will have to manually put names and email addresses in. But once you've done that, everything will then just go straight onto the PSG form. It will automatically happen. You don't need to do anything else. When you're ready to send out the PSG, you know, 2 months into the job, you click send and it goes. You know, because I said I cannot ask people to do this if it was so cumbersome. It just won't land. It's the best I can do. I would rather you didn't. I would rather once you put the names in, that every time you had a trainee, that group was just, you know, just automatically inserted. I've been told by NES Digital that that's not possible because there are so many groups and there's all sorts of governance issues over people. So unfortunately, you are still going to have to put names in, but it's only once per post as opposed to multiple times.
Greg says, with the move towards more community placements in the foundation programme, what provisions have been made for staffing within secondary care? I'd be concerned that the trainees in secondary care would then be under more pressure if there are fewer FYs to cover the same workload.
With regard to expansion, we've had trainee expansion. So this year we have, over the next 3 years, we're expanding the foundation doctor cohort by about 53 across Scotland in each training year. In Tayside, we're getting an extra 9 F1s and this year, and then we're getting an extra 12 F2s. So we're actually expanding, and we've been able to do this with the development of foundation expansion. And that was to meet the requirements of ScotGem, or not just ScotGem, but the graduate entry to medicine, and also the fact that 5 years ago there was an expansion of medical students to meet the requirements. So they won't be taken away from secondary care, but we'll be expanding further into primary care.
Excellent. No other questions on the chat at the moment. If anyone has a question, they could stick their hand in the air, or they can, well, virtually at least, or they can put into the chat. I'll take the opportunity to remind you that if you have missed any grand rounds, or you want to watch this grand round again, then you can go to our YouTube channel, which is far too cumbersome for me to read out, but I've put it into the chat, so you could just click on it, or you just go into YouTube and search for Dundee grand rounds, and it's the first thing that pops up. Like, subscribe, and tick the wee bell to get all the notifications. Nikki just says thanks, no question there. So I don't think there's any more questions. Thanks, Fiona. That's really, really important bit of work there, which you had a lead on. I know how much hard work it is to try and revamp a curriculum and get these things through. So well done for that, and thanks for coming to Grand Rounds to talk to us all about it. Next week there's no grand rounds. That was a planned break with nothing, but then I think the first week in August, Sarah Ulstaff from Sexual Health is going to talk about the impact that COVID and lockdowns particularly has had on sexual health work, which will be fascinating as always. So thanks again, Fiona, and I'll sign off there. Thanks very much.